hours, you can also submit those in the chat box rather than the Q&A. Without further ado, I'd like to present our moderator for this program. Her name is Dr. Shelby Leach. Dr. Leach is an assistant clinical professor at SUNY College of Optometry. Dr. Leach, I now hand this over to you.
Awesome. Thank you, Betsy. Welcome, everyone. Thank you so much for joining us tonight. Really looking forward to this lecture. As for our financial disclosures for this evening, most of us have none, although one of our speakers, Stephanie, she works as executive director for Project Let's, and they will be discussing a little bit further about what that's all about. So as Betsy mentioned, this is part 2 in our disability justice frameworks for optometry. Today we're going to be discussing skills-based crisis response for optometrists, faculty, and students. So a little bit of introduction of each of us, as well as an image description. So I am a white, femme-presenting woman. I have a black shirt on today. I have dirty blonde hair, and I have a white background behind me. As Betsy mentioned as well, I'm an assistant clinical professor at SUNY. I work with 3rd and 4th year students in the pediatric, infant vision, and children with disabilities clinics. I'm originally from Canada. I got my OD degree from UC Berkeley, and then I also completed my pediatrics and primary care residency there. I've been at SUNY since 2018, and I'm currently working towards a master's in public health through SUNY Albany online. I'm interested mostly in advocacy and public policy for disabled kids and vision care. We'll be joined today also by Dr. Rima Bakru. She's an optometrist who specializes in developmental vision and neuro-optometric rehabilitation. She began her practice, Brooklyn Vision Therapy, in 2020 and has been on faculty at SUNY College of Optometry since 2016. She's also an alumni of SUNY Optometry, where she went on to complete a residency in neuro-optometric rehabilitation. Dr. Bakru has also had experience in mental health first aid and peer counseling and crisis intervention. Jenny Liu is a 4th year student at SUNY Optometry. She is the founder of the college's chapter of Project Let's, and additionally is the advocacy chair of Spectrum, the college's LGBTQIA+ club, and is Justice Ambassador of National Optometric Student Association's Political Action Committee. Prior to optometry school, Jenny received her Bachelor of Arts at University of Pittsburgh with a major in philosophy, minors in studio arts and chemistry, and a certificate in global studies. Informed by their own lived experience with mental illness, neurodivergence, intergenerational immigrant trauma, and disability, Jenny is dedicated to intersectionality, transformative justice, community building, and healthcare as a human right. Jenny hopes to someday work at both the micro and macro levels of creating equitable, accessible, and inclusive eye care and affecting systemic change for all marginalized populations.
Thank you so much for the intro. Real quick, I'm joining you all tonight from the unceded lands of the Lenape and Munsee peoples, also known as Kerhonkson, New York. And I am definitely joining you all as a 4th year student, but also as a student within these different frameworks of justice as well. And I am a light-skinned, femme-presenting Chinese person. I'm wearing a black shirt. I have side bangs with dark brown hair tucked back in a ponytail. I have a window next to me and some beige walls behind me.
Thank you, Jenny. And then lastly, we have Stephanie, who is a disability justice cultural worker, educator, organizer, parent, somatic and ancestral healing practitioner, consultant, writer, and the executive director of Project Let's. Their work specializes in building peer support collectives and community mental health care structures outside of the state. Stephanie comes to their work from the positionality of being white, Latinx, Jewish, MAD, autistic, disabled, and a survivor of psychiatric incarceration and sexual violence. They have extensive experience as a facilitator, curriculum developer, and consultant for mental health policies, program development, and access-centered practices. Stephanie is invested in disrupting multiple carceral systems, which disproportionately harm and kill our community members worldwide.
Hey everyone, thank you for joining us, and glad to have folks in this space who were here for the earlier part of this workshop. I'm Stephanie. I am a white non-binary person. I have on hanging floral earrings and a colorful necklace with a green shirt. I am sitting in a wheelchair and I'm in my living room. There's a flag on my wall, some paintings and many items. And I am speaking to y'all from Narragansett and Wampanoag land in so-called Providence, Rhode Island.
Okay, and then we have some acknowledgements to make. To the next slide.
So to give some context for our event tonight, as optometrists, we deal extensively with patients who are visually impaired, and we address treatable and or preventable visual impairments. However, oftentimes we receive very little information during our actual optometric training that centers the lived experiences of and knowledge of our patients. And so this workshop is really trying to view the profession through the disability justice movement lens, and also introduce different historical contexts and like different defining concepts that help us to kind of shift our conceptions of how we can align the profession into disability solidarity. So as the abstract was sent out to you all tonight, tonight's webinar does build upon the last one, but if you missed it, that's totally okay. We're still going to go over some of those big topics as well. And then from that, we're going to talk more specifically this time about heightened situations of crisis response within patient care and also other interpersonal contexts. So we're going to try to challenge ourselves to question our willingness and our desire to outsource patients or students or whoever else, our colleagues, in moments of distress, trauma, or crisis. And as we've been seeing, our understanding that police do not always make us safe is widening, and both students and providers are asking, what does make us safe? So what kind of skills do we need to cultivate or better engage in peer-led de-escalation? And how can we also center our practices of transformative justice in our work to interrupt harm and violence that gets perpetuated? And we'll also address how optometrists can better support disabled, mentally ill, and neurodivergent patients who are in distress or crisis, and what skills are needed in order to center their autonomy and self-determination in our practices. In terms of access, so access is a practice. For tonight's webinar, we do have auto captioning on, but we know that this is still a very limited form of access for folks. Ideally, ASL interpretation is important to have in these spaces as well, because without it, we cut out an entire language and culture for deaf folks who may be in the audience. And also that we know that oftentimes auto captioning doesn't always capture people who don't have American English accents. And so we don't want to exclude those folks as well. And building upon that as a demonstration, we really want to show that access needs are something that we hope our optometric community will consider as the norm, not only for events, but also in clinic and academic settings. And again, if anyone in the audience has any specific access needs, you can definitely message Betsy or any of us in the panel to let us know. If we need to slow down or take a pause, we can also do that. And and then also sitting with discomfort. So a lot of these topics tonight can be heavy topics. And we really want to make sure that we're centering the lived experience of folks who are mentally ill, neurodivergent, disabled, those most at the margins and most excluded, those who are least considered the norm. So sometimes this may bring up discomfort for you all. And we want to be able to recognize these moments where we may have personally been harmful or perpetuated a system that has been harmful to people despite our personal orientation to want to help. So this space is really to challenge what is commonly accepted as the norm. And and then content note from staff.
I do not have it. Do you have it?
It's okay. Yeah, I can read it. So so also during this training specifically, we're going to talk about content related to suicide, self-harm, altered states, trauma, violence, restraints, psychiatric incarceration, and other topics that may be uncomfortable and difficult to engage with. And they can also be personally activating. So we're asking all of you in the audience to take care of your needs throughout the training and take space to take a pause if you need to. And then if and when you start to feel discomfort, we're asking you all to assess internally whether or not you're in a growth zone, which is uncomfortable but necessary for change to happen, or if you are in a panic zone where you are no longer feeling safe, you are highly activated or unable to be present with this training. So we will use content warnings, but it's not our intention to leave out or dilute the harmful and upsetting realities that disabled, mad, mentally ill, and neurodivergent folks often encounter daily in their medical settings.
Okay, so this is just a table of contents of things we'll be going over today. We'll be redefining safety and what that can mean to different people, talking about harm reduction, critical skill building, sharing a few different experiences within the clinic, and talking about boundaries and taking care of you. We have a Q&A with Justice Shorter. It's a pre-recorded Q&A similar to last time, so I hope you guys enjoy that. And at the end, we can have time for an open discussion and live Q&A. So with that, we will jump right in.
Awesome. So just to give some context to Project Let's, which is the organization that I lead, and we are responsible for a good amount of the content in the training tonight. We're a grassroots organization that's led by and for folks who have lived experience with disability, madness, neurodivergence. And in our last session, we talked a lot about the different language. So if that is something new to you, I definitely recommend viewing that session. And really focusing on building peer support collectives and community mental health structures that exist outside of the state. And we come to this work with an understanding that a lot of what we call care and what we call treatment actually creates more trauma. And if our goal as optometrists is really to create safer and more inclusive spaces for our patients, then this is something that we're definitely going to want to think about and try to integrate into our work. Awesome. Just a quick note about this idea of supporting people who are facing oppression being like political or a belief. And I think a lot of how people show up in our clinical spaces, a lot of the ways that people experience disability and experience mental illness is informed by, triggered by, or caused by systems of oppression and the way that we move through the world, and finding ways to support our patients through that, regardless of our own beliefs and political alignment, is a central value to doing this work in an ethically aligned way.
So some guiding questions for us tonight as we move through this training. We want to make sure that we can take away lessons that we can apply to not only crisis situations, but even situations where you're being confronted with a patient who is upset or angry at you with something, or not angry even at you, but just angry for some reason. So these are some questions broadly: is how do you react to danger? Do you go into fight, flight, freeze, or fawn? If you don't know what one of these terms are, feel free to look it up. And then also, how does your identity impact how you respond to others in crisis? So how does it influence your understanding of safety? What do you feel most unprepared to handle? That's absolutely important when establishing our boundaries. And then also, what do you do when you feel triggered? What are your ways of regulating? And then how do you process and release the difficult information you hear? As many of us, I'm sure, when you leave a long clinic day, what are you doing to release different things that you've experienced? And then what 3 things can you do to center yourself? So yeah, try to apply this to either your practice, or if you're a student in the audience, apply it to your academic experiences as well. So moving on, we want to talk about redefining safety. Safety in the context of mental health system, safety usually means agreeing not to hurt yourself or anyone else. I think many of you have probably heard of this, where it's almost like part of a diagnosis situation, is like trying to figure out if a person is safe. So that kind of framework oftentimes puts people in this constant assessment or evaluation, and this decreases our ability to be able to care for ourselves, right? So those of us who are labeled as unsafe, this creates a huge power discrepancy in the relationship. So like if I disclose that I'm suicidal, I might lose my autonomy because I'm not viewed as safe. But if I don't, then I might not be able to get the care that I need. So giving an example of this, imagine a patient or a student discloses to you that they don't feel safe. And so typically the most common way that people respond, and this is a way that we want to try to avoid through this training, is a fear-based framework. So oftentimes people become afraid and they let the fear drive these impulse reactions that can either cause the person who's in crisis to either shut down or face further trauma. So some examples we have here are, like someone says, I feel unsafe, we should call 911, or like, we're going to refer you to social work right now, or like, you should take a leave of absence, for example, to students. Or, or saying like, this is not my job, like I'm not your therapist. Or, or even things that you sometimes think aren't harmful, like saying, but you have so much to live for. In asking questions like that, what are we going to do to keep you safe? So real safety exists in the context of culturally respective, mutually responsible, and trusting relationships. So this means no judgments or assumptions. So if someone's disclosing something to you like this, you can respond with saying something like, thank you for telling me, thank you for feeling safe enough with me to share this with me. How can I help you feel safe? Or can you help me understand what it means when you say that you don't feel safe?
Awesome. And just another example of what that can look like with folks who either hear or communicate with voices. Under that fear-based framework, we might say something like, well, you need to take medication to stop the voices, right? Under a medical model, hearing voices, not normal, not good, need to treat it, cure it, and get rid of it, right? Saying something like, are you safe? Will you sign a contract? Again, in referencing this norm, right? Like you're not supposed to hear voices, or thinking that patients are saying this to get attention, or to gain access to certain treatment or certain types of medication. And the way that, we want to move towards, again, the exploration-based framework, what do the voices mean to you, right? What are they saying? Like allowing this person space to make sense of their experience. How does it make you feel to communicate with them? What has been helpful about it? What's been hurtful about it? If you could describe what this has been like for you, what would you say? And what support do you need from me? I think overwhelmingly, we as a culture have, been taught to believe that people who hear voices, that they're all violent, they're all telling this person to like do terrible things to themselves or someone else. That's, not the case actually for a large portion of people who hear voices. Many of them are neutral. Many of them are healers in their own rights. And we'll talk about that in a bit as well. But just wanting to give y'all a bit of an example of what it could look like to approach a situation from that lens. Awesome. And I think in line with all of this, when we're thinking about redefining safety, we can't possibly have that conversation without taking a deeper dive into the inherent links and between policing and the mental health system, and how they are connected through, what we would call carcerality, right? Anything that is getting entrapped by the carceral system. So you'll see the term carceral ableism on the screen. And that, again, in the first session, we talked about ableism as the interpersonal and systemic form of oppression that disabled and mentally ill folks experience. So with that, carceral ableism is referring to the many ways that ableism and its harms are reproduced and exacerbated by police, prisons, confinement, and punishment. And I think, I want to lay the disclaimer that, again, if you don't have personal lived experience with this side of the mental health system, you might not really understand these links. And this is something that is really important to move towards an understanding of. It's actually critical for the survival and well-being, particularly of psychiatrically disabled, mentally ill folks. So the first one being that engaging police in a mental health crisis response will never be a safe option for patients. Having a conversation on the abolition of police in general is a conversation for another day, but in the context of this situation, we know that to be the truth. We know that mentally ill folks are 16 times more likely to die in a police encounter. Over 50% of police deaths are disabled and mentally ill folks, and over 75% of incarcerated people, if not more, probably likely more, if not all, are disabled and mentally ill. And we know that oftentimes communities have a lack of resources, and the only option that people know of in a crisis situation is calling 911. And that is always an escalation to what is happening. You are having a person who is experiencing big emotions, who is vulnerable, and encountering that with a person who has the ability to literally kill you in seconds, it is not going to ever increase safety. So we can go back and forth talking about, well, should we just train police more? Should we just train them better? Should we just pair them with social workers? All of those solutions reinforce the same core problem, that why can't we think better than this? Why can't we dream bigger than this? Why do we have to have such a violent response to folks who are in crisis when we know it's not working, right? Again, overwhelmingly in the mental health system, we see time and time again this conflation of treatment and punishment. If you're trying to help me, why am I sitting in the back of a police car handcuffed, right? In this country, there is no way to access voluntary, non-coercive, urgent psychiatric care. That's something that needs to structurally change within medicine, right? The only real way to do that is by going to the emergency room and risking an involuntary hospitalization. We also know and really need to start thinking about these overlaps between prisons and psychiatric institutions. We talked a bit about this last week, and just wanting to name outright that involuntary commitment is a form of incarceration. And as you can see that quote on the right-hand side, right, that this is a system that contains people. It takes away your locus of control, your ability to make decisions about what happens to you, when things happen to you, what you eat in the morning, when you go to sleep, right? These are systems that offer surveillance. You are being perpetually watched all of the time. You are removed and isolated from your community. And again, what happens to your body is dictated to you, right? Both of these systems say that if you are not behaving or acting in the way that is deemed to be appropriate or the norm, that you no longer get to make decisions about what happens to you and what happens to your body. And that cannot possibly be healing. We also know through research that the risk of suicide actually increases after a psychiatric hold. So if the entire goal is to decrease risk, we're not doing a good job of it. Also, research that's come out of Harvard and has been backed by the American Psychiatric Association shows that even the most well-trained experts in clinical risk assessment are only successful 50% of the time, the same amount of times as, flipping a coin, right? Random guessing. So we are incarcerating all of these people based on literal random guessing. We actually have no idea who's going to kill themselves, who's going to harm someone else, when they're going to do it. We don't have any good tools to accurately predict that. So again, a lot of different reasons, and really thinking about, mental health providers, social workers, again, are not exempt from that. They have the ability, in the same way a police officer can incarcerate you in a jail, you can be incarcerated in a psychiatric facility and have all sorts of treatment forced on you, right? So really an imperative for us all to start looking at these links, to start listening, right? There's an entire movement of psychiatric survivors who emerged because of the violence of the mental health system decades ago. And unfortunately, not much has improved. So again, as providers, it is our imperative to really, not just within the mental health system, looking at the carceral nature of medical systems as a whole, right? But in the context here, wanting to draw attention to some of those links.
And just quick question to kind of pose for the audience too is, oftentimes when we talk about like suicide prevention, it's about reach out for help is kind of the number one thing. But just kind of posing the question is how do you think that this entire carceral framework might impact someone's ability to disclose or simply ask for help? Next slide. Sorry.
No worries. And again, just to be clear, of some of the links between psychiatric state and interpersonal violence. Some of this I already mentioned. There's this focus on compliance, right? This happens in medicine too. Things are done for your own good, for your best interests. And actually, whose best interest? The best interests of the provider, the best interests of the insurance company, or the person in front of you. We also tend to see isolation, gaslighting, discrediting, right? I think this happens a lot in medicine, and we talked a bit about it last week as well, especially when your patients have certain diagnoses in their record, right? Allowing that to influence your judgment as a provider and how much you're willing to believe that person, right? And leading that into, often folks are seen as these unreliable narrators of their own experiences, this use of restraint and coercion and force, using, cycles of harm, punishment, criminalizing survival. And even with restraint, right, we're always hearing, well, that's just what we have to do for safety. It's like, safety for who, right? Restraints, every psychiatric survivor that I've ever spoken with, myself included, has never felt safer by restraint. So if we're going to say that it's about safety, then let's be clear about whose safety we're talking about. And really working to build alternatives to things that we know are harmful, but we keep doing because it's like, oh, well, we don't know what else to do. And there's a lot of room for growth there as well.
So we're going to talk about harm reduction, which we did talk about in the last event as well. And also Kiara from the last event, our pre-recorded lived experience speaker, had made this awesome handout with definitions and resource guides to learn more. So if that hasn't been sent out yet, it will be sent out to you all. So what is harm reduction? So people, when we talk about like crisis response, I think oftentimes people freeze and they're like, I'm supposed to fix everything. Like, and no, that's definitely not the goal, is to be able to fix or solve everything. But it should be to reduce harm and ensure that people have access to safer options, right? So some So this entire framework came out of the HIV/AIDS crisis organizing, and as well as advocating for safe drug use. So yeah, we're basically wanting to have you look at how we can create conditions that lead to less crisis moments and how we can kind of reduce the chance of harm, right? Like who are we trying to protect? Who are we trying to keep safe, and when that does actually occur. So yeah, anything you'd like to add, staff?
I think that's a good kind of introduction. And I think, again, when we're thinking about harm reduction in the medical context, we're thinking about, as was talked about last week, not making judgments about the choices that people make, and not having kind of a moral lens on the care that you're providing for folks. So just wanting to give an example of what harm reduction can look like in practice. Let's say you have a patient and you notice recent self-harm scars. And just as a side note here, as somebody who has self-harmed on and off for over a decade, it is, for me, has been the number one reason that I have delayed necessary medical care, because I have not wanted my doctors to see recent self-harm wounds and have that trigger some form of a hospitalization, which has happened in the past when I've sought medical care for unrelated issues, even like months old scars. So that is actually like a huge issue and thing that prevents a lot of folks from seeking care in the first place. But if it is something that you notice, right, we should have some type of lens, some type of understanding that self-harm or self-injury is not actually the problem, right? Like there's another problem, and then self-injury is how somebody's coping with it, right? So if we understand that, and if we also understand that most people use some form of self-injury in some way, right? Some are more socially acceptable than others. Like extreme dieting and exercising is a form of self-injury that we've totally normalized, right? Cutting, less socially acceptable. We also know that this is something that looks different across cultures and is not directly related to a suicide attempt. So if we take all of that into consideration, then we can explore with someone what could be supportive, right? We could explore whether or not they actually want to stop. And if they do, offering support, offering resources, maybe exploring what is underneath the self-injury, but recognizing that this is not inherently like a cause for immediate action, immediate referral. This is something that, we can build our tools and capacity to handle in a much more interpersonal way.
So trauma-informed care is also something that we talked about at the last event. And I really liked how Kiara at the last event had put it, was she said that trauma is any moment where power is taken from you in an unexpected way. And so we want to assume that everyone has experienced some form of trauma, is capable of experiencing some form of trauma, and be aware of what's going on with the other person. So if this person is in crisis and they've experienced trauma, we want to make sure that we're honoring that they're experiencing strong emotions that may be triggered from that trauma. And then also keeping in mind that what sort of trauma the person's what sort of trauma that person experienced, like it may you don't have to ask people about their traumas in order to be sensitive to them, basically. So you can basically have conversations with that person and honor fully their experience without getting into the details.
Awesome. I think, another thing that we can do in terms of preparation is starting to think ahead of time, right? Like, what tools do we have to work with? What are the situations that could come up? And what are the tools that we have, right? I think, thinking in addition to some of the questions that Jenny asked in the beginning, right? How do we respond in the moment? Is that the way that we would respond if we actually like sat down and thought through what like the best response or outcome would be, right? Thinking about in our group, in our practice, is there someone who's particularly skilled at de-escalation that we could bring in? And lastly, a question that I love, right? What do you need in order to respond to situations the way that you would like? Is that having a sensory room in your office that has, low lights and weighted blankets? So if a patient is having nervous system dysregulation, they can access that room, right? What are the ways that we're not even thinking of that we can build into our practice to be more inclusive and to prevent escalation of crisis moments? I'm going to skip over this for now. I think I'm going to follow up with a resource to pod mapping, which is a really great tool for building resources and support in community. In the follow-up, we'll send a whole like outline of what this looks like and why it's useful for y'all. Cool. I want to talk a little bit about building a crisis and safety plan. So this is something that we typically do with all of our folks. This is not something you'll necessarily do with your patients, but just to give you an idea of what would go into something like that, thinking about the person's guidelines for how they would want to be responded to if they're in crisis, what a crisis situation looks like for them, what their plan is if they're in crisis, right? There could be different plans for different kind of states, different timelines for taking action, and plans for a worst case scenario. So these are things that we are typically encouraging folks to, to have some self-awareness of and figure out what that looks like for them. And I think, in the context of a clinician, y'all have plenty of intake forms that you use, collecting all sorts of information from patients, and something that, might actually serve, for your patients' use, or thinking about some additional intake forms that would be optional and voluntary. And I want to be super clear that if you were to implement something like this in your practice, you need to be very clear about like who has access to this information and what you're going to do with it, right? Let's say like you have these answers from a patient and you end up calling emergency services. Are you going to share this information with emergency services? Like I would, want you to be very clear about what that looked like. But the idea being that if we actually have specific responses for what somebody, would want to happen in a crisis moment, like that is the best form of de-escalation that we could ever ask for. And this is, again, not something that would just be for people who have like prominent psychiatric histories, right? Anyone is capable of going into crisis under the right circumstances. So thinking about, during a mental health crisis or period of activation, is there anybody you'd like us to contact, right? Somebody might have a partner or a parent who would actually do a much better job of de-escalating the situation than a police officer, right? Thinking about if there's any specific triggers you'd like your care team to be aware of. For a lot of trauma survivors, like dentistry is really triggering, for as an example, right? So maybe, listing, if I was the patient, saying, a trigger for me is when my doctor, does things or uses tools without explaining to me what it is and telling me like the process of what's about to happen, right? And then you have access to this little sheet and okay, this person needs us to like really do an explanation of what's about to happen. I love this question. I recently was asked it for the first time ever by a like muscular therapist. And it was, have you had any invalidating or upsetting experiences with doctors you'd like us to be aware of? I love that question. I was like, yes, like this man cares about not re-traumatizing me. And immediately I was already like feeling a sense of like connection with this person, as someone who's had a lot of really negative experiences with doctors. So pro tip, include that question somewhere. Other questions: how can we best support you if you're in distress? Do you have any current mental health providers, healers, peer supporters that you'd like us to contact, or have contact information for? And the last one being, do you have any existing crisis or safety plan or psychiatric advance directive, which is a legal document, that you'd like us to refer to or have on record? And again, it doesn't even have to be something that's specifically about like you and your office. Like a person could be in your office and get a terrible phone call that something very traumatic has just happened and start, having a panic attack in your office, right? There are all different types of situations that can come up, and having some type of record of people's preferences helps to assure that autonomy is preserved in really difficult moments. All right, we're gonna talk about some tools for crisis situations on a more like nitty-gritty level. And I wanna share this quote by Pat Deegan, which says, "Help isn't help if it doesn't help." And it's very simple, but I think it really gets at the core of what we're talking about here, that, it's not really up to you, as a provider to dictate what is supportive or what's helpful to a patient. That's something that needs to come, from the ground up. And again, if our goal is to be, the best and most competent providers that we can be, that should be something that, we care about as well. All right. So just a couple of guidelines for how we would want to think about and approach a crisis moment. Really wanting to get into the belief that like this person is the expert of their own body mind. And again, I know that goes against a lot of like medical education, but really something that we want to center and work towards. Knowing that when someone's in crisis, you probably aren't going to be able to support them like all by yourself. But again, we don't want to be compromising that person's autonomy, doing sneaky things, telling them, yeah, I'm just going to go get you a glass of water, and then actually go call like your security team, right? That's not being transparent. That's not prioritizing informed consent. We also want to be cautious of when, our desire to take action in a moment is actually rooted in our discomfort about somebody's mental state, right? Rather than that person actually being in crisis. A lot of people just get super uncomfortable if they see somebody like stimming or moving their body in certain ways, or slurring their words, right? And I think, we want to push back against that idea that people need to like behave, speak, perform in a certain way, that is, oftentimes very racist, very white supremacist, to have notions of like what like a put together person looks like, right? And that is really important to recognize as well. We also want to watch ourselves, right? We want to avoid responses that are centered on fear and control and anger. It seems very intuitive, but there are studies that show that approaching a crisis situation calmly will help keep things calm. Saying this as someone who has a very whiny and cryy almost 2-year-old, and if I start getting worked up, I cannot possibly de-escalate my child. Then we are two people in crisis and we're both looking at each other crying, right? And that is not a good situation. So we want to make sure that we're able to show up in that moment as grounded as possible. And if not, we want to find somebody who can, right? We want to tap somebody else in. We also, as like on a bigger level, we want to be making a commitment to non-coercion, to anti-force. This is not just within the context of mental health crisis. This is in the context of everything, right? If we need to touch someone, we want to tell someone, we want to ask for consent to do that. Really important. And again, we want to be using all of these different person-centered tools that we are showing y'all to try and create the conditions necessary for the least restrictive, the least like violent option for support. There are lots of different ways of doing that. And we're going to follow up with some resources for y'all around certain tools that you can offer your patients. We don't have a ton of time to go into like the nitty gritty of those today. Awesome. So for me, when I'm called to a crisis moment, when I'm supporting someone, the way that I'm going to break it down in my head is these kind of 4 moving parts that may shift around depending on the need. But typically there's like a certain logic and certain flow to a crisis moment. First things first, we want to offer and support this person in accessing safety and stabilization. Nothing can happen if this person is feeling so overwhelmed and so activated in their body mind, asking lots of questions, right? Oh, can you explain to me what's happening? Tell me how you feel, right? This is a moment where we need to really focus on figuring out how we can prevent this crisis from escalating and ensuring safety for this person, building rapport, sharing your name, right? Like these are things that we want to kind of get on common ground, give space. Then we kind of want to take a look at a kind of an informal needs assessment, right? We want to be taking a look at the core need, trying to figure out what this core trigger is. A lot of people in crisis get overstimulated or triggered by certain environmental factors. It could be the lighting, it could be a certain word that was just said, sound, not having basic needs met around food or water, needing to like have access to movement, or just being triggered and not knowing why. That can definitely happen. But I think when we start going down this like rabbit hole of trying to like figure out all these things of what's happening, when oftentimes there's one very core need, for example, working with, pregnant people, or, new parents. Oftentimes new parents who are in crisis will be talking about all these things happening and this trigger and that trigger. But what's really underneath it is that they are so exhausted and they just need to sleep, right? And if we can figure out what that core need is, we can come up with a way to de-escalate and long-term plan to continue avoiding those situations in the future. De-escalation, we're going to talk about a little bit more in a few minutes. This is really thinking about how we can keep things cool, how we can avoid re-triggering this person. And again, long-term planning, right? If this is someone who's going to keep interacting with you in your space, what can you do as a provider to ensure that, a crisis doesn't happen again, is one way that we can think about long-term planning. All right. So I want to talk a little bit about suicide. And I think, there's a lot of taboo and hesitation and fear around suicide. And we could be doing a whole session just on this. So I just want to cover a couple of major bases if this is coming up for you. First of all, suicide itself is a process. For most people, this is something that is not going to just happen in the blink of an eye. There is some type of thought around it. And at some point, a person has decided that this is like an acceptable solution to some type of like unbearable circumstances, pain, etc. People talk about like the neurobiology of it, almost like the way that we reinforce a habit, right? That things start to go wrong and automatically it's like, okay, I should just kill myself. And that just becomes like the first thing that comes up. It becomes the reinforced thought, the coping skill, the way out for people. And our ability to intervene is very much dependent on where somebody is at on their own journey, right? We have a world that is extremely unlivable for so many people. And the current focus on suicide prevention is extremely individualized. It doesn't actually make space for the ways that this world makes people not want to live in it, right? And we know that by simple things, simple studies like looking at when the parents and immediate community of transgender youth, when they actually use pronouns that affirm their gender, the risk of suicide decreases significantly. So when we frame suicide as this solely pathological mental illness related thing, we really miss the bigger picture that very simple things, right? Such as like using someone's like correct pronouns has the ability to shift somebody's entire course of life. So the entire kind of current field of suicide prevention can be really wonky because we don't actually talk about why there's a lot of good reasons why people don't want to be alive. And if we actually want to help someone, we have to be able to acknowledge that. That kind of leads, Jenny, did you have a comment? Okay, sorry. Okay, I thought, no worries. Cool. That kind of leads into making space for feelings, right? Oftentimes, this might be something that just like builds up and bubbles out. You might just be the first person that this person is disclosing about this or has access to speaking to about this. And I think, for me in like a clinical setting, like I'll be like at a doctor that it's not even like directly about my mental health, but my records will show my psychiatric history. So I'll just get like a very like, oh, like, have you had any thoughts of harming yourself? And it will feel very like disingenuine, right? Very clinical. And I think it's not something that's actually based on making space for someone's feelings. And similarly, before we start jumping in with solutions and alternatives, we have to be willing to listen. Other things to keep in mind is that, suicidal people often feel like burdens. And I think doing whatever we can, to reinforce the opposite, without saying like very like mantra like things like, oh, you have so much to live for. Oh, like your family loves you, right? Like we don't actually know what the circumstances of someone's life is. And so we don't want to make excuse me, y'all, make these big blanket statements that end up feeling very like, yeah, you could have said that to anyone. It's not really about me specifically. And the last note here, really wanting to avoid anger, shame, blame. I think a lot of people's go-to response when people are suicidal is being like, oh, but what about your kids? And what about your family? And, trying to say that, that your death would just like be so inconvenient really decenters the person's experience and the pain and distress that they're experiencing.
So I'll jump in for this. This graphic was really helpful for me to understand, and also as someone who has experienced suicidal ideation myself, it was good to be able to visualize. Oftentimes, I think as providers, we're kind of asking, like, how do I know if my patient who is experiencing suicidal ideation is in crisis? Because there are these different levels, right? So you could go from a very like baseline level, just having random intrusive thoughts, to someone who has a means, plans, and intents. And so that's kind of the way to evaluate when to kind of offer support and be there with that person is if they are at that level where they have a plans, means, and intent.
Awesome. And I think, some of y'all might be saying like, well, sometimes there just is like risk, right? Like someone saying things that are really concerning and I don't know like how to navigate that. And I think, the point of this is not to say like, don't address it, right? It's about the way that we are addressing it. So instead of, framing things in this very, again, clinical way, do you have a plan? Do you have the means to carry it out? Are they lethal? If you're feeling this way, I'm going to have to call 911, right? Kind of making these like, undercover threats. And I think, we can start to ask different questions, right? Do you want to talk about what's making life so hard right now? Did something painful happen recently? Is there something that you need to make life more livable? My personal favorite, I'm feeling really overwhelmed by a desire to fix this. How can I be supportive for you right now, right? Throwing it back in this person's court and giving them the space to tell you exactly what they want or what they need. And when we get into moments where we don't know, we just do way more than we should. Like that's a key to just take a back seat, ask questions, and again, try and have some humanizing element to it. And I also want to say, like, I completely understand that, like, a lot of what causes the like feeling of dehumanization in the medical room is not necessarily like it is in part the individual role of the doctor, but it's also the structure of the medical system, right? That is like constantly encouraging you and forcing you to spend less and less time and do things faster and more standardized. And that is, why when we talk about things, we talk about them on an interpersonal and a systemic level. That's something that will have to change in order to actually do this the right way. You can't possibly do this the right way if you have 5 minutes with your patient. It's easier, it's more efficient to just call and get a police officer to deal with it, because you've got to go on with your day. You've got other patients to see. And like, we have to like resist that urge every step of the way.
I'll jump in here as well. I found this quote super powerful the first time that I heard it. So I think one of the reasons why we have a fear-based response when someone is coming to us in crisis or is activated is that fear that like, oh, they could harm me. Or like, what if there is a weapon involved? So more often than not, if an individual in a mental health crisis grabs something as a weapon, it's gonna be in self-defense because they're scared or they're experiencing paranoia. And sometimes you can say, I see you're holding a knife in your hand. Are you feeling scared right now? Or can you trust me enough to put that knife down while we talk? Or even acknowledging, I know you won't hurt anyone, but I'm concerned that there are people around who might think you will. So is it okay if you put that down?
Awesome. I'm going to talk a little bit about altered states, or what we would refer to probably typically as psychosis, as mania. I think, the first thing that we want to do, we want to slow down and recognize that, you are probably not in danger simply because someone is behaving in an unconventional way. Every single aspect of our society has tried to ingrain in us this idea that, people who are, talking to themselves, seeing things that you're not seeing, any of that, saying things you can't understand, that is inherently dangerous. And we really, really have to unlearn that. People who experience altered states, mentally ill folks in general, we are much, much more likely to experience violence than perpetuate it. Obviously, everyone is capable of perpetuating violence, but having it be so inherently linked to like psychosis in particular is very, very harmful. I would say another really important aspect of supporting folks experiencing altered states is not challenging, their reality, right? Because that's something that's very real for them. It profoundly escalates things to repeatedly tell someone who's having their own reality experience that it's not real, right? Actually, when you think about it, every one of us has our own reality experience, right? Like if I'm in pain, nobody else feels the pain inside of my body, right? You just like have to believe me. Well, we have testing, right? Things like that. But in terms of what it feels like to be in my body, right? Nobody else has access to that information. And I think people typically tend to want to say that's not happening, right? You're crazy. You're seeing things, you're delusional. And we want to be really careful with that. We want to avoid that tendency and recognize that their experience is very real for them.
Something that also comes up for me with this as well is as optometrists, if a patient is presenting with a visual disturbance, or so we call it, we can often end up invalidating what people are seeing because, if there's no clinical explanation for their visual experiences. So we should try kind of moving towards saying something like, I believe that you're seeing that. But clinically, I don't see any disruptions of the tissues or any changes to the health of your eyes that are concerning to me, but you're always welcome to come back in for us to check you again if you notice any changes to what you're seeing. I just want to completely validate that what you're seeing is real to you, though.
Awesome. And just a couple of other notes on like best practice for engaging with someone experiencing altered states. I think the first one being one of the most important, to dive in and join them. Again, resisting that urge to fight back and trying to like prove them wrong and prove that your reality is the correct one, right? Just saying, oh, that's interesting. Can you describe what you're hearing? Can you tell me more about what you're seeing, right? Trying to meet them where they're at and join their universe rather than demanding that they join yours. I think another important point of not assuming it's paranoia, right? Let's say you have a patient who comes in, sorry, all this is extremely loud fire truck passing, hold on. Okay. Let's say you have a patient come in who is like describing, how a different doctor was treating them and making these comments and saying these things and saying that, oh, I think that they maybe contacted this other doctor, and feeling really harmed by something that you're thinking, well, that sounds, kind of like a conspiracy theory. That doesn't sound right, right? Like we want to hold space, particularly for the ways that negatively racialized people, have been dismissed and gaslit, and their experiences have been called paranoia when they're actually very much rooted in like our mutually shared reality. But what we know about like psychosis is that these are mental states that extrapolate very real things. And we know this because the content of what we call psychosis, of like voices, right, actually differs significantly depending on geographic location and cultural context. In the US, the voices tend to be much more aggressive, much more violent, and much more focused on government and state surveillance. In other countries, that is not the case. And the content of thoughts, or what we would call delusions, tend to be different. People tend to have much more neutral experiences and encounters with their voices. So wanting to hold space for that as well. And the last one, there are many people who have cultural, spiritual, and non-medicalized beliefs and perspectives about hearing voices, experiencing altered states. In many cultures, the most upheld and respected community healers are people who would be deemed psychotic in the context of the US, right? So very much wanting to hold space for that as well when we're working with folks who experience altered states. And again, some of y'all may be saying, okay, like, yes, I hear you, but sometimes people really do believe, things. This person might believe I'm trying to harm them when I'm really not. And I have approached this in a trauma-informed way. I'm on their side, that type of thing. That is what we would like call in the clinical context persecutory delusions. I don't love that language, but I'm giving it to you in quotes because that's what we have access to right now. Really, my best strategy for this is really trying to find and validate the aspects of truth in what they're saying. The way this shows up is almost like two truths and a lie, right? There's like a foundation of truth, and then it just like will tend to like go one step further of something that is being like misinterpreted in the environment. So really wanting to hold space for the ways that our beliefs have real impacts, recognizing the way that trauma and ongoing trauma creates hypervigilance, which makes us less equipped to perceive danger accurately. Almost like we are just constantly taking in too much information that's like referential to danger, and it's hard to make a determination of what's harmful. So really saying to folks, right, like even if these perceptions are true and strong, right now they are serving to rob you of a sense of safety and stability and what you deserve. So how can we move forward in navigating that? You know, maybe just removing yourself, you know, as a doctor, if you are encountering a situation like this with a patient, and really being willing to hold compassion and humanity for folks who are having experiences of misinterpretation. All right. As we are moving towards wrapping up, I want to share some final thoughts around de-escalation. And I love this quote from Brene Brown. Rarely does response make something better. What makes something better is connection. Really thinking about, you know, at the end of the day, the best way that we can show up is as a person who is invested in the mutual safety and humanity of the person across from us, and not so focused on like trying to have, you know, the best response, the best tool, really wanting to build that connection and establish that foundation. So when we think about de-escalation, again, this is going to come from a place of empathy, of patience. If we're going to do it, we want to be willing to collaborate with the person in crisis, right? And not just tell them what to do. If we're not willing to do that, we want to tap someone else in and pass it off to someone who could approach the situation from a more grounded place. Again, prioritizing helping this person access physical and emotional safety. Keeping their, you know, as it's kind of called, voice and choice centered. Can you tell me what you need, right? Asking questions, but knowing, again, some people might not be able to communicate verbally or communicate at all. And this is, again, de-escalation. After we have created that initial sense of safety, we don't want to be bombarding folks, right? We also want to take account of how power dynamics around historical oppression could be present and also triggering the situation. And maybe it's best to find someone who has more shared aspects of identity who can work with this person. I'm going to offer this just as a resource. I'm not going to go through it right now. It's pretty self-explanatory. It comes from the Wildfire Alliance and is thinking about different strategies for de-escalation, right? Validating this person, validating where they're at, right? It makes so much sense to me that you're feeling this way. Wow, you're right. I did touch your arm without consent. It makes so much sense that you'd be feeling unsafe right now, right? Validating that experience. Being curious, you know, what is that again? What does that mean for you? Asking all those questions, being vulnerable, which I know is very much discouraged in, you know, medical practice, you know, but every time a doctor has, you know, gone there with me, I've appreciated it on a personal level to the extent that you're comfortable, right? It doesn't have to be like an in-depth account of what you've been through, but some kind of like, I understand, and really showing that. And again, focusing on building community, connection to community. These are all really great strategies for de-escalation, and encourage y'all to take a look at the different statements and different, you know, types of options that are available to you. And similarly here, you know, we know that a good support network is the single most powerful protection against becoming traumatized after any type of upsetting or distressing event, right? Developing like a significant trauma response is not actually inherent to what happens, right? That's about the response afterwards. And if somebody is not met with a response that enhances and centers their safety and their needs, that's when we really risk developing more significant, what we would call PTSD type responses, right? So on the screen, just a couple of different options for ways to ground and co-regulate. You can offer to, sit with and look at the person and breathe, take deep breaths in together and co-regulate. Asking them to think of moments where they've, felt safe. Many of y'all have probably heard of like the 5, 4, 3, 2, 1, asking folks to kind of identify things in their immediate environment, to help ground them. Lots of different tools, as well. And, wanting to leave this as a resource for y'all. I'm going to skip this slide. Cool. We kind of highlighted this a little bit earlier, but just wanting to name it specifically again, we really want to move beyond empty words, right? So, let's say a patient discloses something they're going through, right? Saying something like, oh, that must be so hard for you. You must be tired, but remember that you'll get through it. You're so strong, right? That's really vague and unspecific. Versus, I know what anxiety feels like for me, but I don't want to make assumptions about your experience. Can you help me understand what it's like for you? Or, I hear you. I can imagine that's been really hard lately. I remember, when it seemed like the only thing I felt was depressed. And maybe this is, again, something that you're not personally comfortable disclosing, just an example. And then saying something like, I do, however, want to recognize the strength it takes to call me for support, right? That's specific, it's observable, it's something that can't be fought and negotiated with, and feels a whole lot better than just something that's really vague and can be applied to anyone. All right, just a couple of quick notes around, if you have done all of the things we've said and you're still considering taking some type of action, we want to make sure that we are still working to center the person's needs, that we talk to them, right? We tell them that this is what I need to do right now. This is the choice that I'm going to make. This is what's going to happen. I can stay with you, while this is happening, right? We want to let people know what to expect. And a lot of people who are going to make a choice like this, right, try to do it very sneakily because they don't want the person to get upset. Well, like, it's their right to get upset, right? And I think that is something that we just have to deal with if we're going to make these choices, and does not mean that we shouldn't let people know what's going to happen. We also, want to be aware in our community if there are other resources, right? There might be mobile crisis response teams or peer support networks that you can connect with that can provide more non-carceral crisis response. And I'm going to, again, leave this as a resource for y'all. These are just questions to personally reflect on when you're taking action, right? Asking yourself, is what you're doing actually helpful, or are you just trying to make yourself feel like less responsible for the situation? Are you considering the consequences of your actions? Is it truly a life-threatening emergency, right? So just wanting to leave this as a resource for y'all to look through, and really ensure that, when we take action, we're doing it for the right reasons. And last thing I'm going to wrap up with here, if police do get involved, the first one being that details can make a difference for harm reduction. So we want to try and give information about the situation beforehand. It may make a difference during the response. It's not a guarantee. Even police officers who are trained in crisis situations oftentimes still perpetuate significant harm, right? We want to, if it is safe for you to use, yourself, your body, be present in the room while this is happening. Don't just leave and allow the response to take place. Make sure that there is someone who, is a support, could potentially help to de-escalate if the response from the police is really escalating the situation. Really wanting to make sure that we don't just leave a person and kind of abandon them in that moment. And as always, really acknowledging the harms of what happens when we make that choice. It might mean that somebody is going to lose their job or lose their kids or lose their life, right? And it is really critical to make an investment in thinking about responding differently.
Okay, thank you, Steph. We're going to transition. I see we have a few really great questions in the Q&A we're going to answer at the end of the session. We're going to now shift into sharing a few different experiences from the clinical and academic setting. So Dr. Bakru, if you'd like to go first.
Hi, everyone. I apologize. I sort of missed the introduction due to a technical issue, but my name is Dr. Bakru. I'm a South Asian female, tan skin, brown hair, wearing maroon scrubs, and behind me is a messy optometric office. So I'm sure you could imagine. So for those of you who don't know me, I'm pretty involved in working with many patients who are disabled or who are sort of in the process of applying for disability. I specialize in vision therapy, most specifically for patients who have experienced brain injury, but also children with developmental disabilities, learning differences, and things like that. And it's a powerful position to be in because, as I mentioned, many of these patients, because they have recently had some type of trauma, are really transitioning into this new identity of perhaps someone who is disabled. Oftentimes they don't necessarily have the services or support system in place. And on top of everything, they oftentimes with brain injury, your autonomic system is dysregulated. So you're even more potentially likely to sort of become triggered or elevated or become emotionally distraught. So all of the tips that we got today were extremely helpful. I have also noticed that in terms of, applying for disability, well, one thing I think this was probably touched on last time, but it's an extremely challenging process with the current systems to obtain Social Security disability, to obtain services. Oftentimes there's independent medical providers who are sort of invalidating your experiences and basically denying you from the basic support that you need just to get by financially, to be able to put food on the table. Many of my patients are in a place where they can no longer work. And so I am certainly no expert, but I am trying more and more to provide as many, one, I think, as we've spoken about, validation is so important, especially with brain injury. Many of our patients, they look okay from the outside. It's sort of a type of hidden disability. And just giving them the time of day during therapy sessions to make space for their emotions, to make space for them to process what it's like to be denied for disability and have to reprove your trauma over and over again. I find that can be super helpful. And kind of touching on what was mentioned before about providing, a space to decompress, I think that I found has been very, very helpful as well. Offering just simple things, or even just starting an exam with the lights dimmed if you know that you're working with somebody who's had a traumatic brain injury, or dimming the lights when you can tell that they're becoming uncomfortable. Being a little bit more perceptive. You can usually tell on their face when they're becoming uncomfortable, and you can make that option available to just stop the exam, to allow them to sort of come back down closer to their baseline. Often I find offering cold water or even like a cold paper towel to the head can be great. And lastly, additionally, just trying to advocate for these patients. I write a lot of letters and reports to try to get them, state-sponsored services. Unfortunately, it's not a perfect system, so I find it helpful to have a lot of community-based resources in my back pocket too. Mutual aid, peer support groups, things like that. So that is my experience, and I'm hoping to take more out of these presentations so I can offer better care and access to my patients.
Great, thank you, Dr. Bakru. I'm going to share a personal experience. So, definitely trying to learn what we've talked about today, how I can take this into different experiences. Maybe you guys can all reflect on something that has personally happened in the clinic with you. As I mentioned before, I do work with children with disabilities frequently. And there was a particular instance where we had a mix on the floor of typically developed children and children with disabilities. The child I was examining, who was autistic, he was older, about, I want to say 14 to 16 years old. So he was larger in stature. And there was an incident out in the waiting room. Now, details aren't extremely clear. And for those of you that may know, we have a new pediatric floor in SUNY. State of the art, fantastic. And we have a room called the chill room. Kind of how Steph mentioned earlier, having things like particular lighting, weighted blankets. In this room, we have, a screen that has a calming, like fish tank on it. We have like an egg chair. So, kind of a thing comes down. So, a child kind of wanted to have some space to themselves. So we have this specific room that we can offer to patients, and it's really awesome. It was not offered in this particular instance, and an altercation happened in the waiting room, and it, again, he said, she said type of thing. But in the end, security was called up. I was in an exam room with a different patient. A student let me know, and I went out to the waiting room, and it was very obvious that the mother of the patient was extremely tense, and got, rightfully so, she's protecting her child. The dad of the other patient was protecting his child, and then the security was there, and the presence alone, I think, really brought up the entire tension in the room as well. No one on the floor really is trained in de-escalation. So looking back, I stood there like a deer in headlights, because I was just told very firmly, stay back, don't get yourself involved, go back, leave the room, etc. And it just was a very tough situation all around. Recounting it afterwards, we had to submit the story of what happened to administration. And I know it was discussed, and I actually don't know what happened in the end. They discussed, does this patient need to be dismissed from the clinic? Now, that wasn't the first time the patient had been there. He'd been there multiple times, no issues before. And again, tough to tell exactly what had happened, whether he was, something was brought it on or what it may be. But it's really unfortunate that, first of all, that was the response. And then that child may be dismissed from the clinic. And especially, I'm sure a lot of there's not a lot of providers all over the country that aren't going to see children with disabilities. And so we are one of the main providers in the area for children like this. So really, really disappointing. And so, listening to today, to last time as well, how could I have responded better? How could people on the floor responded better? And what is our responsibility to, the people around us, to try and educate them, my coworkers, my students, the staff, and as well as, how can we only involve security when need be? Is this a protocol? You know, maybe we need to go back into the protocol for what happens in situations, because we are at an academic institution. I'm sure there's some sort of handbook with some sort of rules, and maybe those need to be addressed and rewritten, because if that is the response that needs to happen, as we've learned today, that is likely not the safest thing for our patients, and that really should be our priority. So that was one particular experience that I thought of when we were going to do this series, and definitely have taken away a lot of things from this talk and the last one, and I hope you guys have as well. And maybe you can think of some instances where things maybe got a little out of hand, how we could have used some form of de-escalation in order to keep and protect our patients nice and safe. And then Jenny, I know you want to mention a few things as well.
Thanks, really. A couple of things that situation also brings up for me is just kind of inherently how inaccessible clinical settings can be for neurodivergent folks. And oftentimes, those considerations of access aren't the norm. And also, like, in a crisis situation where there's like many people in that same shared space, is like everyone having more people on the same page about how to respond and provide support is important, because I myself was also in the middle of the optical at SUNY once, and there was a very heightened situation with a very angry person who, rightfully so, had waited longer than expected because of communication issues with, when this person was supposed to get seen. And like everyone in the room froze. And I was like the one person who was just talking really calmly to someone who was like escalating their voice volume. And so everyone was just like, what, like, what's happening? And then security did get called, unfortunately, as things were starting to de-escalate, and that re-escalated things because the person who was experiencing the crisis was also, negatively racialized. And so then that brought up a lot of trauma as well. So that is something that comes up for me too, is just like ensuring as many people as possible in our community being on the same page about things, and trying not to like have carceral responses be our go-to thing that we want to do first. Like, how can we kind of come together as a community first? And then the thing that I really want to bring up in terms of my own personal experiences too is actually looking at things from like the academic side of things. So in optometry school, it is a very rigorous program, as you all know. And, it's not easy the first year transitioning from a completely different life, like, coming into a whole new city for a lot of folks, not having support systems. So like I myself had gone through some mental health crises first year and didn't know who to turn to. And when I did turn to somebody who I thought could help, the response was sort of like, I'm not here to be your therapist, or like, why don't you just try to study harder if your grades are being impacted? Like that's what you need to focus on to do better. And I think we need to take a step back and always remember that, like, people's mental health is this very holistic understanding. Like, what are the material conditions that are leading me to have suicidal ideation or other things? Like, it's not always so cut and dry. And I think like having a level of vulnerability in what should be very professional spaces is important to hold space for too. Literally just asking someone like, how are you doing? Like, what's going on? You want to talk about something? Or like, if you don't feel safe talking to me, like, is there someone I can connect you with? But like, maybe not even being like the first response is like, can I connect you to a therapist because I'm pathologizing your experience and I think there's something wrong with you too. So that's kind of what comes up for me. And like really great resources that we've tacked on to the end of this presentation too. There's a book called Laziness Does Not Exist by Devin Price. They are a social psychologist who talks a lot about like kind of these root causes of what we label as laziness. Other books include academic ableism. And then, yeah, so you'll see all of that at the end, but that was kind of my piece that I wanted to share. So real quick before we get into the pre-recorded session, and then we'll try to answer as many questions at the end too. We can kind of go to the next slide, Steph. Is boundary setting. So this kind of goes back to, you know, how can we take care of ourselves as well? How do we make sure that we don't get activated in situations of crisis? Our pre-recorded speaker, Justice Shorter, also brings up, she brought up the same quote by Prentice Hemphill, is boundaries are the distance at which I can love you and me simultaneously. And so these boundaries, you know, I think when we talk about boundaries, sometimes it's very abstract, but they can be many different things. They can be material, physical, mental, emotional, being asked to disclose your own psychiatric history, that's like definitely, you know, you can have a boundary on that, and spiritual. So, you know, we like to view all of ourselves as helpers because we are in a helping profession, but that doesn't mean that we can't forget about ourselves as well. Yeah. And then, you know, asking ourselves these questions here, like, what do I need to feel safe? And yeah, like kind of also going back to like the co-regulation too. Yeah. Anything you'd like to add on, Steph, for boundary setting?
I think you really covered that well. I think the last thing I would say is around knowing when, under what circumstances you might be willing to like break your own boundaries, right? To support someone during a moment where they need support. Awesome. And then just a couple of suggestions around strategies for internal preparation and external processing. Thinking about how if we are going to face a difficult or stressful situation, we want to have time and skills and ways to prepare for that. The gold band of light, the seed, the waterfall are all different types of like 30-second visualizations that you can do. There are definitely different strategies. And then thinking about external processing after a difficult or stressful event has occurred. What are the ways that we are able to decompress and create some more space for ourselves?
Right. And then last thing we have tonight is a pre-recorded Q&A. Jenny pre-recorded this with Justice Shorter, so thank you, Jenny. Justice Shorter is a disability justice advocate and Black Disabled Lives Matter amplifier. Justice is the co-creator of a celebrated framework for applying disability justice approaches to disaster assistance, an emergency management method that acknowledges histories of harm, centers intersectionality, and prioritizes leadership by Black, Indigenous, and people of color with disabilities. With a steadfast commitment to international development and inclusive humanitarian assistance, Justice is currently the National Disaster Protection Advisor for the National Disability Rights Network, where she advises the 57 federally mandated protection and advocacy agencies on any issues related to pandemics, fires, disasters, and other emergencies.
Okay, thank you so much for joining us tonight, Justice. We just have two kind of broad questions for you to kind of elaborate whatever you'd like regarding. And yeah, okay, so the first question we have is, can you briefly describe the justice frameworks you operate with, how your lived experience informs you, and what sorts of work you've been up to, both for your job and outside of work?
Well, first off, thank you for having me. I'm so excited to speak to this particular group of budding professionals. I am really eager to be in community with you all and being able to do that, even though I can't fully participate in the panel. So I'm excited about this opportunity to do the video component. In terms of the justice-based movements, I would say that all all of the justice-based movements and kind of a granular sense are interconnected and are inextricably linked. So if you think about disability justice, there can be no disability justice without racial justice. There can be no disaster justice without disability justice. There can be no gender justice without disability justice. And you can say the same about economic justice or transformative justice. And the reason why we typically say this is because people with disabilities, particularly Black, Indigenous, and other people of color with disabilities, are more often than not at the very center of those conversations in terms of the disproportionately disparate impacts. As we think about the compounded forms of marginalization that people have to contend with on a day-to-day basis, right? So a lot of my work is built and shaped and stands on those foundations of understanding that we have to examine these issues from a multitude of perspectives and angles. So let me just give you an example. If we are talking about gender justice issues, well, that's also a disability justice issue, purely if you just look at the historical trajectory of this country and how often women of color, and particularly women of color with disabilities, have received forced sterilization procedures on their bodies, right? And have been denied the opportunity for informed consent, right? So we think about this from a gender justice perspective. When we talk about environmental justice issues, that is a disability justice issue. When you see some of the forms of environmental degradation and erosion and the climate crises and what type of impact that has on the body and mind, and how those things can be both a cause and contributor to disability. So we have to understand these things from interlocking positions, right? So that we can be able to bring forth solutions that are truly substantive and that truly help those who are the most impacted. That should be the primary driver. Now, you also asked why I care about these issues, and I think it is because it is tethered to, tied to, connected to my very essence and being. I am a Black, blind, lesbian woman. When I walk out the door or when I stay in, I live at these intersections. I do not come to visit. They are, you cannot sever them, right? They're inseparable. They have to be kind of connected and joined because they are all a part of me. And I think that is the piece that really drives me moving forward. It is a part not only of my ancestry and thinking about those who have come before me, but it's also something that gives me hope as I think about the future, making sure those who were sidelined, those who were pushed into the shadows are then now, with a concerted effort by us doing the work, are brought into the center of these conversations. And I try to do that both through my professional work in disaster protections and crisis response, disaster assistance. I try to do it there. And then I also try to do it within all of the other independent and external projects that I work on, involving disability justice and racial justice work and all of the other justice-based frames that I mentioned before.
Wonderful. Thank you so much. That really also reinforces, we talked about intersectionality at the beginning of our first event, and framing it as how these justice frameworks also are interconnected is super important. Yeah, and then going on to our second question. So in what ways do you think optometrists can expand their ways of helping that centers visually disabled and Black, Indigenous, and other people of color disabled folks, as well as folks in crisis?
Well, often when I think about crisis, I think about the transference of power, and then I also think about time. And so when I first began to lose my vision, someone who was teaching me a course, the course was Activities in Daily Living. And she mentioned to me, she said, listen, the difference between a problem and a crisis is time. And little did I know at that time, that phrase would be the very thing that kind of helped to guide me throughout my entire career. And so something is a problem if you have enough time to deal with it. Certain eye issues and certain considerations regarding health, they are a problem if you have enough time to address it, if you can proactively address what these issues are, if you can do preventative care, if you can do proactive procedures to try to get at what some of these issues are. But if it becomes a crisis is one does not have the time to properly care for those issues and properly deal with those concerns. If one does not have health care, if one does not have transportation to be able to get back and forth to clinical visits, if one does not have the different access accommodations needed in order to have a fully informed and a transparent conversation with their healthcare providers, right? It becomes more of a crisis-like condition whereby people are engaging with medical practitioners at a crisis point, right? At the last minute when they are in more of a critical need, right? So I think these are the types of conversations that I'm really interested in having. I'm interested in trying to meet people where they are. I'm interested in community outreach. What does that look like? So I often work in disasters and emergencies, right? How are you all showing up in those spaces as well, right? So I talked about disasters and emergencies being both a cause and contributor to disability, and thinking about what those consequences look like, how they show up in the lived realities of disaster survivors. But what does that mean in terms of what you all have the capacity to do? How do you show up before, during, and after disasters to help individuals who are in need of not only medical assistance, but also community-based supports, individuals who are houseless, individuals who have no forms of health care, individuals who perhaps have been pushed into carceral-like conditions or environments because they have lacked certain understandings from medical professionals that they've engaged with before. And I mean that in terms of the conveyor belt type of mentality, constantly pushing people from one group to the other because you may not have the time to give them the type of care and attention and answer the questions that they may come with. An idea, maybe, well, let's send them over to a social work, or let's send them over to another group. And that may be the triggering point. That may be the place or the condition or the circumstance that lands that person in carceral-like conditions, group home settings or nursing home settings or other facility-based settings or carceral-like settings that deny them the type of autonomy and agency to live fully and freely. Those are the types of conversations I'm interested in having. What does a life look like for the patients that you seek to serve? And how do you convey a sense of hope, a sense of healing, not just in terms of a medical perspective, but we're thinking about this holistically, right? We're thinking about what do you know about the resources that are available in your community, and how can you help to create them should they not be in existence, right? How do you help pull together patients without revealing any, personally identifiable information, but how can you announce different groups or different clubs or different activities that can help build community, right? What does that mean in terms of mutual aid? But then also, if I could just say this lastly, I think having a discussion and delving in more deeply around pain and pressure. So I have glaucoma, so I know a little something about pressure being put on the optic nerve. I think about this more expansively, though, because when we talk about pain and we talk about pressure, we think about these things as prohibiting the process of preparedness, right? So when people are in substantial amounts of pain, when people feel a tremendous amount of pressure, it makes them far less likely to be able to properly prepare for a crisis-like event, should it take place. So what can you all do within your profession to recognize the different pressure and pain points in the lives of those you serve? So not just as it relates to the physical body, but what does that look like also in terms of the mind? What does that look like in terms of the community? What does that look like in terms of the relational building and connections that people are trying to bring forth? What does that look like in terms of trauma, right? And how that shows up in the body as it relates to pressure and pain points, right? How do we understand these everyday lived realities of folks? And then lastly, I'll just say, understanding who can be a first responder. How are you responding to crises? How are you prepared to do that? And how can we also ready others who are around you, not only your colleagues and those who you seek to work with professionally, but what does that mean in terms of your community? How can we prepare for what the eye conditions are, the health conditions are for the communities that you seek to serve? Because when they go unaddressed, they can often emerge or gradually grow into crises, right? So how can we respond to that once it happens, but then also how can we prepare, prevent, mitigate these things from happening in the first place? And those are conversations that can only happen when communities, in particular for this conversation, communities of color are at the center of those conversations. It's not something for us to prescriptively say from a more distant or abstract perspective. It is something that needs to be spoken about with a degree of detail and grace and patience and understanding that centers those voices, not just casually, not just from the periphery, but actually make sure that we are making substantive movement. There's motion, there's decisions that are being made that actively prioritizes those interests and the needs of those communities that we seek to serve. That is my question. I think that is my motivation. And that is what I hope you all will continue to work on as you move forward.
Thank you. You've given us so much to think about. I guess just wondering if you have any more input on what, even as a profession, organized advocacy could look like, either within or without institutions.
Yeah, I think being able to work outside of institutional restrictions is important. And I also validate and affirm the very real experiences of people who are working within those entities as well, right? So I think both forms are indeed valid. It is just all about your preference and what do you think you can make the greatest level of impact, right? And also understanding your true capacity. So I think about this in terms of boundary making as well. I follow a person by the name of Prentice Hemphill, who I love. They have a phenomenal podcast, but they also do a tremendous bit of writing. And they talk about boundaries as the distance between loving you and loving me simultaneously. And I often ask folks to think about that in terms of their work. You know, I love my work enough to do 2 extra hours after, I'm set to be done. But I also love myself enough to only do 2 hours more after I am done. For some people, in respect to the question that you just asked, some people may say, I think that I love this work. I love this cause enough to be able to push it from the outside, right? Or to be able to push it from the inside. I also love myself enough to know my capacity, to know my limitations, but also to be able to explore things in a more expansive way that are different than what people may have traditionally told me was possible. And I think that's what's really important. So how can we look at this from a place of artistry when we talk about advocacy? Because there can be creativity, there can be pleasure, there can be a lot of joy and inspiration in the work that you do in terms of advocacy and activism. And I encourage you also find a balance in that as well. So I was just trying to bridge the gap and make the connection between those frameworks as well.
Perfectly said.
Yeah.
Thank you so much for everything you've shared. I think you've given us a very important and a very nuanced perspective on how to view these things and how we can try to move forward and center specifically people of color, disabled folks, and visually disabled folks in crisis, as well as preventing crisis.
Yeah, for sure. And do let me know if there's any way I can come back to be of assistance, and I will send you over my Twitter handle, and folks can sync up with me there if they want to continue the conversation.
Great. I hope you all enjoyed that conversation, a little Q&A between Jenny and Justice Shorter. Definitely a lot of things to think about. And we do have their Twitter handle at the end of this. Steph, you just want to go to the next slide, and we're just going to answer the Q&A questions here. We have a few minutes left. So I'm going to leave this open for any of you to answer. But the first question is, how do we handle HIPAA when a patient mentions suicide? Are we able to tell a loved one who is taking care of them or their primary doctor?
So I can go first here to try to answer this question. The first thing that kind of comes up for me was something that Steph was mentioning earlier was, when we're working with a patient who mentioned suicide or a patient who's in crisis, there shouldn't be any surprises. We shouldn't be, reaching out to their loved ones without their consent. So we should, if they are telling us like, the best thing for me right now is to call this person in my life, then like ideally they would be giving you that consent to, disclose who the person is. Yeah.
Yeah, I think even for like mental health providers are not able to do that without like some type of like written consent. And the law will change depending on the state in terms of like giving direction of when someone is in imminent risk of connecting with law enforcement or psychiatric hospitalization. But from my understanding, if a patient disclosed that to you and you did not have consent to discuss private medical information regarding that patient's care, that would in fact be a HIPAA violation.
Yeah, and I'll just elaborate. Legally, I know that if it's in the best interest of the safety, then again, maybe state to state, but you're legally allowed to. But hopefully you guys, after considering today, are reconsidering what is the best interest of the patient. So even if the law says, okay, you can, HIPAA's okay with that one, is it appropriate for you to do so regardless? Good question. The next question, which the last two are kind of related. I work with children frequently. We know that the pandemic has been correlated with an increase in mental health issues, particularly in teens. I suspected some of my teen patients are suffering from mental health issues. What is a human-centered response in this context? Does it make sense to share my concerns with the parents? What is an appropriate referral or suggestion/connection to resources? What about getting consent from the patient in front of their parents, etc.? How can I help increase the odds that the patient will have a positive, supportive experience? And then just kind of connected, the last question was, what if the patient is a minor?
Yeah, I can start. I would say that if your goal is for the patient to have a positive and supportive experience, I would not have that conversation in front of the parent. I would show that you are invested in maintaining some level of privacy, even if they are a minor, right? That's really important. I would not share my concerns with the parents before speaking directly with the child. And would definitely, again, depending on the presentation of what's been going on, if the patient has made like vague statements that kind of indicate that they're struggling versus something that you're observing, whether that be, self-harm scars, right? Anything of that nature. I think the way to like bring up really difficult information is, again, making it as like specific and observable as possible. You said X to me. I witnessed X. And that made me feel concerned about X. And so I wanted to check in with you. I'm not here to make any choices on your behalf. I wanted to see if you wanted to have a conversation about this, if there are any questions you have, resources you'd like to be connected with, or if I could offer some resources, right? Again, putting everything back in that patient's lap, right? Because if you go right to the parent, that just reinforces to the child, like, I was right to hide this and I should continue to hide this in the future.
Something that comes up for me for this, and I think Steph just gave a really great example in real time of like nonviolent communication too, is just like utilizing that process. If you don't know what nonviolent communication is, go ahead and look it up. There's great books on how to utilize the 4-step process of nonviolent communication. That is also a great tool for de-escalation, so that we're not using language that is accusatory and that may further escalate situations. And then just not directly answering this question, but semantically, I think something that was really striking to differentiate that, like, actually I learned from Steph was that mental health issues being exacerbated during the pandemic is a direct result of material conditions and not directly due to the pandemic itself, if that makes sense.
Right. And I'll say, I work with a lot of kids. And so it's nice because most of the I'm working with students. So I'm able to say to the student, oh, can you take the parent out to the optical and, start putting their name on the list, getting them outside of the room for whatever reason it may be. And then I'm able to talk one-on-one with the student. If you have a tech or a scribe, having a way with them so that they're able to be able to get the parent outside of the room. So then you're able to talk one-on-one with the patient. And then one more question, and of course, if you guys have any more, feel free to submit. How can we maximize patient autonomy for the vulnerable and disabled?
You want to start us off, Jenny?
Let's see. So I think we've definitely touched on this in everything that we've shared. But, maximizing autonomy, the one thing that we go back to a lot is like not assuming what is best for someone else. Like, especially like disabled folks, oftentimes like they're talked over, and yeah, so when we consider, these multiple interlocking forms of marginalization and the ways that people are more vulnerable, not talking over someone and assuming what's best for them is how we honor their autonomy. And harm reduction, centering that. If someone's saying the best thing for me right now, let's say like the example at the last event was someone is a cigarette smoker, and like obviously like we are not advocating for tobacco products, but if that person just like that's the one thing that they need for them to like relieve their stress, they just need one cigarette, like harm reduction is a framework for that as well. Yeah, so that's kind of what comes up for me, but also Dr. Backer, feel free to jump in too if you have anything.
I just wanted to mention in terms of, whether it's, I think this comes up a lot with like non-speaking patients or wheelchair users. We tend to infantilize them, thinking that they either don't understand us, they cannot make decisions for themselves. We don't talk directly to them, and we talk to either their parent, their caregiver, whoever it may be. So just make the assumption that they are fully capable of understanding you, fully capable of responding back to you, and then go from there. So I think just being aware of that from the beginning.
And just to add on, in terms of, I think another way that is sort of more systemic and perhaps something that we need to change, which has been hinted at by Steph, especially in healthcare, is just because we have time limitations. I mean, these patients will take more time. That doesn't mean that because we have a time limitation, we should sort of railroad like what the best option is, or talk to their caretaker to make all the decisions for them, when they are capable of making those decisions, but perhaps they need another way to communicate them, whether it's writing it down or signing it, or just I think I'd like to see our profession and the medical field in general like learn to adapt so that we can allow for self-autonomy for these patients, and not let our limitations kind of impose what we think is best for them just because we're in a rush.
Excellent. We only have 2 minutes left, so this will be the last question. Many communities have programs like Crime Stoppers, where pictures of child predators and other violent criminals are published in the paper or shown on the television, asking for information on these people. They ask for help from the public interest. How do you respond when you see your patients' photos in these columns? I personally haven't experienced that. Does anybody want to chime in?
I kind of want to take 2 steps back and just talk about what we define as crime first too. Like obviously, like certain things that harm others, for example, sexual violence and like violence to people who are more vulnerable, or harm to children, like those are considerably harmful things. But then the ways that our carceral systems frame crime, and like how, like when we talk about mutual aid, like we're not talking about vigilantism either. So that's another consideration. So that's kind of what's coming up for me. I'm not exactly sure how to answer this question more directly though.
Yeah, I guess I would say that I think, I'm not like an optometrist. I don't know if there's like a specific something like about something like this if you're training, but if not, then I would say that like as individual people, we have a lot more and even as professionals, like a lot more like wiggle room than I think we often like think we do. And that might just like come down to like your personal like ethics along the scale of like where you fall like as like an abolitionist and as somebody who is either invested or not invested in more carceral solutions, in the same way that like if you are see somebody who just like stole a wallet and they're a negatively racialized person, like you make the choice whether you're going to like reenact potentially more harm by getting those systems involved. And I guess that's that happens on that individual level.
Thank you for that answer. All right. If you just want to go to last slide stuff, our contact information is there. Betsy, are you there?
I'm here.
Awesome. Thank you.
No, you're welcome. No, thank you all for such a great presentation with such important detail. I hope that all of our attendees were able to grow from this, learn from this, and if they have any questions, as you can see, everyone's information is here, or reach out to me in case you miss anything. I want to thank you all the presenters, everyone for joining tonight. We do hope that you'll join us on September 29th, I believe, for the last program. The recording of this will be emailed as well as on our website. Other than that, I just want to tell everyone have a great night. I thank you all for your time and all of your work. Take care.